This is a webinar series of the Greater Broward EMS Medical Directors Association. My name is Dr. Peter Antebi, and I represent all the following folks you see here on your screen. Essentially, Broward County, as you all know, as most of you know anyway, is composed of multiple municipalities, and many of which have their own medical director. But we've all banded together. We use a cohesive set of protocols, and we try to bring to you folks really pertinent, cutting-edge education, and today is no exception. I did want to point you towards our website, which has all the protocols on it, which are searchable. You can download the PDF of the protocols as well. And then if you see the training tab at the top, that's where today's webinar and also prior webinars will be posted in a YouTube video format. So if you'd like to view this webinar or have other folks view it, you can feel free to do so right here at the training tab. And that's the website gbemda.org or .com, either one works. If you are a paramedic and you're looking to get CEUs and you have already a EMS Docs username and password, simply fill it in here. If you're a guest, you should click here at the bottom, and the guest passcode will be stroke 15. This will all be in a follow-up email as well. If you do press guest, if you're a prior guest, simply fill in your email address. If you're a brand new guest, click here at the bottom. And again, the passcode is stroke 15. Just some housekeeping things before we get Dr. Mueller-Kronast on here. Your microphones have all been automatically muted. We really emphasize that for questions, you type in your questions early as you have them. And then at the end, I'll be moderating those questions. And without further ado, I'd like to introduce today's speaker, who's Dr. Nils Mueller-Kronast. And he's a neurointerventionalist at several hospitals in Broward and Palm Beach County. He's been around for quite a long time, and he provides excellent care for several of those hospitals that I mentioned. And Dr. Mueller-Kronast, you want to go ahead and give yourself maybe a better introduction than I gave you, and then I'll give you the controls.
Sure. Most of you will know me. I've been in the stroke scene here in Florida since 2010. I'm going to begin the webinar so you can see my title. There's no reason for me to narrate that. I'm the Regional Stroke Director for Tenet South Florida and coordinate the stroke quality in all of our 10 hospitals. And we'd like to use this opportunity to educate you all on the new stroke data that came out in the International Stroke Conference. And without much further ado, I'm going to jump into the title, Stroke of Science, Groundbreaking Studies. I think they're truly groundbreaking, once-in-a-lifetime studies. What we're going to cover today is extensive. I have a disclosure. I work for one of the I don't work for them, but I do a study for one of the major manufacturers of one of these stroke retrievers. The objectives today, we're going to impact the time delay. We're going to review the impact of time delays on IV TPA effectiveness, which is, I think, a very important topic, and what Target Stroke has done to improve those times, and different versions of delivering stroke care and how to improve times. We're going to review, as one of the core topics, the new endovascular trials, the 2013 negative trials, and then the new recent trials, Mr. Clean, Extend IA, Escape, and Swift Prime. You should be familiar with all those names. They're going to be mentioned, over and over now from here on forward. And then I'm going to highlight some important differences. And then we should discuss the needed changes in the system of care, what's required to deliver similar outcomes as were achieved in those trials. So we have a lot of territory to cover, and it's going to be going pretty quickly. So we're going to focus on this first piece. And one of the things you well know is that the efficacy of intravenous TPA decays very rapidly over time. In the first 90 minutes, it's 4.5 number needed to treat to get 1 year normal outcome. In the second 90-minute, it decays to number needed to treat of 9. And in the third 90 minutes, or the extended window, it is only effective with a number needed to treat of 14. And beyond that, there's really no benefit. So it's very, very important that we move the treatment to where the drug really has its potential. and not delay. And unfortunately, right now, we're still not doing a very good job. It's, by the way, similar for the endovascular arena. At about 6 hours is where you lose the effectiveness in untriaged patients, meaning patients are not super selected with perfusion imaging. So again, there's absolute time is brain. That's the message that has to be in our minds all the time. Fortunately, we've made significant progress over the past few years. A study from Funero in 2014 outlined that with the advent of the Target Stroke Initiative, we've really ramped up our awareness of door-to-needle times and improved our process. And you can see on that bend in the curve that we're really making significant progress. At the same time, there's still a lot of work to be done. TPA utilization is increasing. We're using more TPA. We're more aggressive about it. We've just this week removed some of the limitations that were sort of arbitrarily placed on the package insert, like seizure or rapidly improving symptoms, but still only about 10.4% with the guideline database right now receive intravenous TPA, which is still an unsatisfying number. Very aggressive stroke centers push that north of 20%. And so this is in part the work of the American Heart Target Stroke Initiative, and we should give them credit for that. And also with Get With the Guidelines. One of the things we don't do enough, and I want to put this out here deliberately, is that we don't really volunteer our data. It's impossible for us to really know where we are in the system of care, how we can improve if we don't share our data. We did so in the International Stroke Conference, where Tenet had 2 presentations sharing their door-to-needle improvement process, how we got from relatively average number to what we feel now are significantly improved numbers, and how this could be done. This could be a model for a lot of people, because it's really not rocket science. This is something that can be done across the board. But you can see we started off north of 60 minutes, and we're right now at a median door-to-needle time of 31 minutes, with almost 90% of patients being treated within 60 minutes or less, and that would be qualifying for the Target Stroke plus SEAL. We'll talk about that in a moment. Why is door-to-needle time relevant? First of all, if you improve door-to-needle time, you have lower in-hospital mortality, you have more frequent discharge to an independent functioning living environment, meaning you go home more often, and you have lower rates of hemorrhage. It's actually safer if you're faster. People always think that if they delay and double check and triple check, they make the treatment safer. It's actually the opposite. The faster you are, the lower the treatment risk will be. We have some publicly available quality metrics, and the established one is the Target Stroke Honor Roll, which means you treat 50% of the patients who arrive at your door with a stroke under 60 minutes. And a number of hospitals in the community have signed on to this honor roll, and the number is ever growing, and I'll go over those in a moment. There's a proposed new rule, and I think it makes a lot more sense to strive for the next level, which is the Target Stroke Elite, meaning you treat 75% of your patients under 60 minutes, or then the Target Stroke Elite Plus, which means you also push your door-to-needle times in half of your patients under 45 minutes. And that's really where we should all be going. It's not enough to give out VTPA. It's not enough to give it to 50%. That's half of our patients under 60 minutes. We have to be much better than that. We should really give 100% of patients under an hour and at least 50% under 45 minutes. And that's where this Target Stroke Elite Plus honor roll is going to become very important, because it really challenges all of us. It's really about being aware of it, putting the resources behind it. This can be done. It's very important. There are a number of facilities that have earned the seal so far. The newest advent, I think, is Boca Regional. I just updated the slide yesterday. There are a number of centers that will join in the near future, like Memorial Regional will join. But what it really should show us is not so much that who's there, but that this is a public display of quality, and that we need to have more of this. We need to have more transparency as to who has what process, not just for the medical directors, where it's very important for the EMS medical directors, but also for the public, because they really are the ones that drive the resources that are necessary behind that. So if there's pressure on the administration, they will make the resources available, and it will lift the boat for everybody. So the message out of this is not so much who's on it, but who's not on it. There are 26 centers in South Florida that are not part of the stroke honor roll, and they're still receiving stroke patients, even though they don't even manage to treat half of their stroke patients in an hour. And that's, I think, something that has to be addressed and changed. We need data to see where we can improve the system of care. One of the things that's actually important is that we're focusing really on the wrong metric, because we don't really know what's relevant. Is it the door to treatment, meaning door to needle or door to groin? Or is it really more the first medical provider to treatment, because that is often very different? Or what's really ultimately important for the patient is onset to treatment, meaning, you know, when did my artery block off, when did I have stroke symptoms, and when did they manage to get it open? So the onset to treatment metric is probably the most functionally relevant one, and that's one we tend to ignore because it's really hard for us to measure that. And I'm going to outline that in this example. There are two well-published stroke systems. One is Helsinki, which is well known for the ultra-short door to needle times ranging between 15 and 28 minutes. Here in 2011, when the publication was stopped, it was 28 minutes. But their pre-hospital times were actually much longer than that of the Tempus project in Bavaria. And so the actual onset to treatment time is 136 minutes. So even though the door to needle time seems short, everybody's real happy with what they've done, the system of care is still insufficient, and the actual onset to treatment time is longer, because Tempus, and I'll show you what that looks like in a later slide, which is a rural telehealth system, actually was able to get the patients to treatment quicker, even though the door to needle times were 12 minutes longer. We are currently sort of in a black hole. We know our own average door to needle time. Average is 38 minutes, median is 32, but we don't know what that orange bar is. We have no idea, are we here or are we there? And that really impacts our patients. And so what we need to strive for as a system of care is to understand from onset to treatment, where are the gaps, where are the barriers, how can we improve that system of care? And there are a number of different successes if you can look at that. For instance, the Tempus time that I showed you and the times in Helsinki, there was a trial in Berlin that looked at taking patients to a hospital, which is the Phantom S hospital bar at 119 minutes. So again, relatively good metric. And they were able to shorten this time by deploying a mobile stroke unit, or STIMO, and they went from 119 to 103 minute onset to treatment time. So an absolute improvement of 13 minutes, and everybody thinks this is really great. But honestly, there are some negative consequences. For instance, it took subsequently 15 minutes longer to get the patient to the hospital, which may impact the access to endovascular care, and endovascular care as of 2015 has just become so much more important. So we really have to have data about our system of care before we decide what is the best system that we should use in our community. This is an example of the Tempus system. You can see these hospitals are as much as 150 kilometers or 100 miles apart from the core hospital. So direct triage to a core stroke center hospital, those ones in purple, is obviously not practical. And they actually struggled with the new science because they had relatively low utilization of endovascular care, and they now need to figure out how to get these patients in these rural regions rapidly to endovascular care. On the right side, you see the STIMO example, where they have this one stroke mobile in the center of Berlin, and they go up to 10 and 15 kilometers out trying to get to these patients. And again, the question is that applicable to our geography? Couldn't we deliver the care faster with the disbursement of hospitals that we have? In Houston, for instance, the stroke mobile may make a lot of sense because the 4 comprehensive stroke centers depicted with the red stars there in the center are all pretty much on one block, and then there's not a whole lot around it, so it makes sense to go radially out and pick up those patients. In our community, it's very different. This is our community, the system of care in Broward, and you can see that there's really an ideal coverage of all patients, with no patient being more than 10 minutes from a comprehensive stroke center. So for us, the system of care may look very different than that, for instance, in Houston or in Berlin. It is actually similar for most other counties. The only exception may be the western part of Palm Beach County, where there's very little coverage, but there's also very little stroke patient volume, so it may not be economically feasible. Miami-Dade is also relatively homogeneously covered. So again, not really the problem that you don't have the care in reach. Just to compare the raw numbers, in Houston they have 4 comprehensive stroke centers with about 6 million people. We have 16, so we have a much better access for our patients provided that each of those stroke centers, actually comprehensive stroke centers, actually functions as a comprehensive stroke center with the same level of quality that we've seen in those trials. So this is sort of just food for thought. How do we improve our system of care? Just a couple of facts on the mobile stroke unit, because it's really hip and it's really cool, but I think it has to be viewed relatively conservatively and critically. The mobile stroke unit has a 3 to 5 mile radius, sometimes as far as 10 miles. The cost of just purchasing the unit is as much as 1.1 million, and then you have the annual cost of staffing with a CT tech, paramedics, etc. So even in Berlin, even in Houston, as far as I know, these are not 24/7 yet. These are still on a research basis. They don't, work all the time. And in Cleveland, for instance, the data was just presented at the International Stroke Conference, and they did about 300 runs with a dedicated dispatch for stroke and ended up giving 17 doses of TPA. So not really a very high yield, and if you translate that into dollars, it's probably not very attractive. The time gained with the stroke mobile in Berlin was 13 minutes. So maybe we can get those 13 minutes cheaper and more efficiently by improving our current stroke system of care. And that's really what we need to focus on. Right now, most hospitals in South Florida treat 50% of their patients beyond 16 minutes of arrival. So we have a lot of time that we can save there first and really don't have to spend a lot of money to improve the process, as long as we put the attention to it, and the attention means public transparency. So if you think about dollars per minute saved, spending money on an MSU versus simply improving our door-to-needle time, I think it's a clear win just to focus on process. We should all be at least target stroke. That should be a requirement, because it's actually a relatively low, almost too low hurdle if we want to play in the stroke arena. So I'm going to move forward and review the endovascular trials. First of all, the relatively frustrating year of 2013, and then subsequently the newer trials. So in 2013, we got these results. IMS-3 was published, which showed no significant difference in functional independence with endovascular therapy after intravenous TPA as compared with IV TPA alone. So here, the bridging therapy failed. Then there was a trial from Italy called Synthesis Expansion that showed that endovascular therapy was not superior to standard treatment. And then MR Rescue, which was a penumbra or MRI-based treatment algorithm, did not identify a patient that had improved outcomes. So very frustrating. We really struggled for a while because, in truth, the outcome of stroke patients doesn't hinge just on a device, but it hinges on the real system of care. So after 2013, we couldn't just give up saying, well, we'll wait for somebody else to do the research. We actually had to continue refining our system of care and continue improving these procedures to get to the results where we are today. In 2010, we received the first retrievable stents that actually had been out in Europe a little bit longer. And similar to the cardiac arena, they achieve immediate flow restoration as soon as you deploy the device. And subsequently, you can remove the device, obviating the need for aggressive antiplatelet therapy. And they have very, very, very high recanalization rate. We're talking meaningful recanalization, which was not achieved in the IMS-3 trial, possibly as high as 90% and obviously less bleeding. So why were the recent trials so much better than the MS-3 trial? The real kicker is really they only enrolled 2% of patients who were treated with a stent retriever, and the stent retrievers were so much better. But they also improved the system of care because patients just took too long to get to treatment. So I'm going to talk a little bit about the outcomes of IMS-3 in terms of reperfusion success. So the good reperfusion, TICI 2B and 3, and you should be really familiar with these terms, was only 48%. So not really a very successful result, and that's why the patients overall didn't do very well. Even though if you look at it in more detail, you could actually prove that for a certain group of patients, there was improvement. For instance, for the patients with severe strokes, with an anti-stroke scale of more than 20, they had, it was not statistically significant, but it was highly trending towards it with a P of 0.06 that they had improved outcomes all across the board. Similarly, when patients had a proven carotid T or tandem carotid M1 occlusion, then patients had significantly better outcomes with 27 versus 4%. So there was already the kernel of the success that we're seeing today in this trial from 2013. And remember, this was technology that went through 3 iterations, starting with IV alone, intraarterial treatment alone, followed by an ultrasonic treatment paradigm, and then eventually went to the Mercy retriever and clot aspiration. What we learned from IMS3, though, is that for every 30 minutes of delay in reperfusion, every half hour the patient didn't make it to the lab and was open, there was a 14% relative reduction in good outcomes. So the probability of good outcomes dramatically decays over time. And again, we get back to the initial paradigm. The first, medical providers and device times are important. You need to avoid all unnecessary transfers. You need to get the patient immediately to the destination they need to be at to get the appropriate reperfusion. And we have similar experience from a stentriever-based registry called the STAR registry that proved that for each hour increase in stroke onset to reperfusion time, odds of clinical outcome decreased by 38%. So again, we need to focus more on our first medical provider to device times. This is the proof from the team in Grady that basically in 2013 looked at their transfer volume and tried to figure out if transfers would affect patient outcomes. And lo and behold, patients who are transferred have much longer picture-to-puncture times, as they coined it. That's the yellow added area, yellow and green area. And with those prolonged picture-to-puncture times, patients had obviously worse outcomes. The transfers increased the mean picture-to-puncture time from 89 minutes, who went directly to a comprehensive stroke center, to 205 minutes. So that's, I have to do the math here, 110 minutes, or almost 3.5 times 30 minutes, if you look at that deterioration of each 30 minutes. And one of the interesting things they learned looking at why that was the case is that the higher level the primary stroke center was, the more triage they tried to do, the longer it actually took them. For instance, if they tried to do CTA, CTP in the referring center, it actually took a lot longer, not surprisingly, because the decision making was a lot longer. The other thing they noticed is that centers that didn't really frequently transfer, didn't have an ingrained algorithm to get the patients in and out the door, had a very hard time doing that in an acceptable time frame. So the less patients you transferred, the longer your times were to get them to the comprehensive stroke center. And with that, this publication documented that it was a significantly increased odds of having poor outcomes. So if the picture-to-puncture time was greater than 270 minutes, the odds ratio of good outcome was 0.18. So really, really very poor, and it was much better if it was less than 90 minutes. And it really didn't matter whether you came a priori with core infarct or not. Time was always a factor. What we needed in this whole spectrum was randomized trials. We needed these trials to prove against a very doubtful community that the technology that we were offering worked, but we also needed to prove that there are certain systems of care that can deliver this. And this is something that we need to explore and follow up in more detail. It was very difficult to recruit into these trials because a lot of the patients were actually treated outside with variable process, and the centers were actually not willing to randomize. Out of 14 CSCs in South Florida, only 4 were involved in these randomized trials. So it's very important that for the future we have more buy-in into data collection. We need to continue to research such, for instance, the Stratus registry, which is an all-comer, non-randomized registry. I'm going to make advertisement because I'm the PI. But there's also the Trigo registry, which is very similar, and the Dawn trial, which is a randomized trial in the very late time window, 8 to 24 hours, that these current studies don't address, where we don't know what the right answer is. A lot of us feel that perfusion-selected wake-up patients can be treated safely and successfully, but we need randomized data for that. So To fast forward to 2014, in October of 2014, we had a similar presentation, first in the World Stroke Conference and then later published in this New England Journal article called the Mr. Clean study. And the Mr. Clean study documented that patients could be successfully treated with endovascular care. It is primarily a bridging trial. The majority of patients were treated with IV TPA. They were all anterior circulation, so not basilar occlusions, and they allowed patients with extracranial carotid occlusions, which are typically much more complicated to treat, into the trial. I'm going to go through the data in a little bit more detail. So this is the average age. The interquartile range is shown. I'll go into the age in a separate slide later on, but you can see that at least a quarter of these patients is older than 76 years in the interventional and control arm. The NI stroke scale is what we typically see with these interventional trials, around 17. And they were a mixture of patients, but the majority were very healthy, which is something that we should also take into account because we have a tendency to jump into and treat everybody, but the results that we see now can really only be extended to premorbidly very, very active and healthy patients. So there was very few patients with a modified ranking score of 2. What was different about Mr. Clean than IMS-3? Well, the difference was that almost all patients, 97%, were treated with a stent retriever. And that really is one of the most important successes that we've had in the treatment of stroke. Is the devices are just simply so much better that they have allowed us to achieve these outcomes. And this is the distribution of clot location. They had a large number of ICAT occlusions, and 2/3 of them were MCA-M1 occlusions. They were very successful in reperfusing. The Tiki score, though, is still left somewhat desirable. The TIC score is much better than what we saw in the IMS-3 trial, but only 59% achieved a TIC 2B and 3, which is near complete reperfusion or complete reperfusion. And you have to keep that number in the back of your head because that will allow you to compare this trial with the other trial that I'm going to be demonstrating to you. So recanalization was very high, as documented by CTA. CTA documented that over 70% had reperfused at 24 hours compared to the TPA arm. And the NI stroke scale was much, much lower, correspondingly in the group that got intervention than the one that got TPA alone. And this is really the most important picture. For the first time, we were able to show that there is statistically significantly improved outcome with a modified ranking score of 34% of good outcomes compared to 19% in the placebo arm. Now, the placebo arm has fared much worse in Mr. Clean, in part because this trial is a trial of TPA failure, meaning the patients that failed to improve with IV TPA were randomized into this trial. Others probably would have been selected out. And so, to some extent, it's a fair trial, though, because that, in many ways, represents what we do in daily practice. If you look at this, there's a couple of interesting results that I really did not expect in this fashion that will prompt me to review some of my practice. For instance, the group that was over 80 years old, we don't have a good understanding of how many patients there really are, but the group here had a better response to the treatment. They were over 80 than the younger ones, meaning that they uniformly do so poorly with medical therapy that it still may be indicated to do the endovascular treatment even though they're older. The other thing that we were able to show is that patients with extracranial carotid occlusions were safely treatable in this trial, which is something that interventionalists have often disputed because of the need for stenting and antiplatelet therapy, especially in the relationship to TPA. What were the factors that influenced the positive result? One of them is obviously the technology. We got better TIC 2B and 3 rates than in IMS-3. We had a very sick population with 26% ICAT occlusions. And one of the things that really is very important also for clinical practice, we confirmed that there truly is a vessel occlusion for offering the treatment to the patient. Nobody would diagnose a large vessel occlusion based on a clinical score alone. The delay between IV TPA and intervention selected patients towards a TPA rescue trial. One of the interesting things is that Mr. King was able to enroll a lot more patients than IMS-3 because they threatened with withdrawal of reimbursement because there was no supporting evidence. Fortunately, that is now over. Going to the next trial, the Extend-IA trial is a very, very important one out of these three trials because it has really the best outcome. One of the things that's notable to look at is they have a very aggressive workflow. Onset to groin puncture at 210 minutes, CT to groin puncture 93 minutes. This is an actual slide from the International Stroke Conference presentation. If you look at their revascularization rates, they're almost too good to be true. 100% TICI 2B and 3. But this is what's reported. The actual number, when they use a slightly different metric, is slightly more conservative, but still absolutely excellent. And I think what's most striking about it is that even with aggressive revascularization, the treatment is actually safer than medical therapy. So if you look at the symptomatic hemorrhage rate in the TPA arm, with 6%, which is what we expect, versus 0%, even though that's not statistically significant. So the TPA and endovascular arm had a much lower mortality. Again, the numbers were too small because there were really only 35 patients in each arm in this trial. And the reason why the trial was stopped prematurely is because of the result of the Mr. Clean trial. After publication of Mr. Clean, the stroke community felt that randomization into these three ongoing trials was no longer ethical, and they were stopped. And this is what came about. This is the premature analysis or accelerated analysis. One of the most notable things about the Extend-IA trial is that we see a dramatic improvement that's also clinically relevant. If you look at the TPA alone arm on the left, it says the median time at home, which is out of, at day 90, how many days have you spent in your own home? That is 15 days. Or if you look at that a different way, you've spent 75 days in an institution of some sort. If you look at the endovascular arm, or the bridging arm rather, that's 73 days. So these patients on average only spend 17 days in a facility, which is absolutely striking, and that should really, in subsequent analyses, point towards a significant cost saving for society as well. So Extend-IA, out of all the trials, possibly because it had the best revascularization results, had the best modified ranking outcomes. 71% of those patients with devastating strokes, large vessel occlusion, went back to having only a minimal deficit with functional independence. And that is statistically significant with a P of 0.01. And the modified ranking score here in the 40% in the TPA alone arm is what we saw, for instance, in the NINDES trial. So this is the real world experience. Endovascular care really is proven here that it's just much more effective. Let's move on to the next trial out of this triad. The next trial, one of the larger trials, was the ESCAPE trial. And one of the things that the ESCAPE trial tried to do is to try to implement a real world approach, meaning how we practice in real life looking at anterior circulation, but focusing on very, very rapid process. CT to groin puncture, 60 minutes. Recanalization in 90 minutes. Very aggressive workflow using retrievable stents and balloon guide catheters, avoiding general anesthesia. The ESCAPE timelines are outlined here, and this is something that we as a system should focus more as an example, because I think a lot of us would struggle to implement and replicate these timelines, and that's really something that we should make transparent and egg each other on so that we can get better in these times. I'm not going to dwell on that. Again, heavily stent retriever based, 77% solitaire, 9% trevo, a couple other devices used. And revascularization rate, TQ2B3, 73%. Modified ranking score, a little bit less good than what was seen in Extend-IA, but at 53%, still almost twice that in the medical arm. Mortality was lower, symptomatic hemorrhage was acceptable. So again, across the board improvement. And if you look at the mortality in the control arm versus the intervention arm, you could see that while not statistically significant, there is still, there's still a significant improvement in how patients are being cared for. And the symptomatic hemorrhage rate was only mildly higher than that in the control arm. Here's the mortality. Again, I actually have to correct it. I think death was statistically significant because the confidence interval was less than 1. So the summary and escape is, and I think that's something that we have to take all to heart. Patients can be selected based on an aspect score and CT, poor man's perfusion imaging if you don't have CT perfusion available. The key issue is to act very fast with these time metrics to achieve very good reperfusion. And if you do that, the number needed to treat to improve one patient is only 3, which is among the best efficacies that we have in medicine so far. Moving on to the last of the 3 trials, because we have very limited time, we'll talk about the SWIFT Prime trial, the most well-known of the trial funded by Covidien. And SWIFT Prime, again, looked at very aggressive time metrics. You can see that the aorta reperfusion times are only marginally longer in the IV TPA arm, 23 and 24 minutes here. Therefore, what we need to focus on in our own community is, time to groin puncture, groin to first deployment. Those are really the metrics that we should make public and share amongst each other, because we need to achieve similar numbers if we want to claim similar success rates. Outcomes, again, across the board improved with a very high number of modified ranking scores 0 to 2. 60% of those patients with devastating strokes were functionally independent at 90 days compared to 33%, almost twice the number. And all the secondary endpoints were in favor. So slightly lower mortality, more people were independent, improvement in anti-stroke scale, etc., across the board. But I think this is the most important slide here. If you look at the treatment effect magnitude, you can see that if you compare the modified ranking score 0 to 2 against the rest, the number needed to treat is only 4. That means per 100 patients treated, 24 patients will have a better outcome. And that's really a fantastic result and is better than that of many other interventions that we offer. So just to summarize it, because this is a lot of data, the good outcomes appear to be predicated on stent retrievers. The vast majority of these patients were treated with solitaires, some of them were treated with retrievals, but stent retrievers, hands down, really made these successes possible. And the therapy trial at this point is unpublished. We don't know really why it wasn't published. It may be published at the European Stroke Conference, but at this point, clot aspiration doesn't have the same scientific support as we have for stent retrievers. One of the things that is really important to take to heart is that outcomes are not device contingent. The device is just one piece in this whole thing. So outcomes depend on time to treatment. If you look at the different modified ranking scores that I've showed you earlier, with Mr. Clean having the poorest, it had the longest average groin treatment time with an average groin puncture at 6 hours. All the other people were done in 75% cases under 6 hours. So we really need to push these patients to be treated under 6 hours, even if we select with perfusion imaging, because that's where we can treat the majority of patients. And obviously, successful reperfusion is absolutely important. You have to have TICI scores north of 70% to really have the same level of outcomes. One of the open questions we still have is, what's the role of anesthesia? Anesthesia was used a variable degree in these studies, and it seems, at least from the Mr. Clean data, that the impact of anesthesia is pretty significant. It may be a selection bias because these sicker patients get anesthesia, but if you look at this presentation from the International Stroke Conference, the effect of intervention, which is the very top level, is almost negated. The middle bar is the one where anesthesia was used, and it's almost the same as the placebo arm. So this is something that we really need to follow up in more detail over time. Next question that I struggle with, is there an age cutoff? And so if you look at these different trials, you can see that there are about 100 patients, 76 or older, in all of these 4 trials. And the number needed to treat in the group older than 80 was actually better, or the response was better than in the group under 80. So we can't any longer from the get-go discard these older patients, but they have to have a very, very high functional status, meaning a modified ranking score of 0 or at best 1. Otherwise, we won't do them a favor. And so this is really something that we have to follow up with further research as to where there is a cutoff that may disqualify these patients in the future. They may still improve better than if we did nothing, but not enough to where we think it's a successful outcome. Is there a lower severity cutoff? This is a very important piece because the lower severity cutoff will predicate when do we screen these patients towards a comprehensive stroke center. And the answer is we don't know. The minimum NIH included in Mr. Clean was 3 and ESCAPE was 6. The others really didn't mention it. But about a quarter was less than 13 or 14. You would think that the majority still lies north of 10. So I think if you start screening with an NIH stroke scale anywhere between 8 and 10, you'd probably be able to capture most of those patients. But we still struggle to replicate that in comparison, for instance, with a race, LAMS, or MENS score, and that's something that we have to do with further research over time. These are all bridging trials. So the majority of patients in these trials got TPA. So the goal is still, it's still standard of care to give TPA first, and we can only take patients to centers that have a very good TPA process. We should not take a patient from a primary to a comprehensive stroke center that doesn't have a very good TPA process, as indicated by Target Stroke or some other seal of quality. Perfusion imaging should probably be standard of care. They were used in Extend-IA, ESCAPE, and SWIFT Prime, and they really helped select out patients with unfavorable imaging. So I think this is something that we're going to see more of in the future. Treating extracranial carotid occlusions, a lot of debate back and forth. That seems to be safe. The symptomatic hemorrhage rates are relatively low if you compare the treatment against placebo. There's a number of open questions. Best technique, should we use a balloon guide or not? Science seems to suggest that yes, so that needs to be reevaluated. Is anesthesia really that bad? That's a question we have to answer in more robust registries. Is there an age limit where functional outcome may be a type of better than medical therapy, yet still too poor to justify the expense of the procedure? Should we treat a 95-year-old that has a improvement from 2.5% to 7.5%? So that's really the question that we have to answer as a community. And then most importantly, can these modified ranking results be reproduced in the community? If we don't collect 90-day modified ranking scores, we cannot prove that we're doing the same thing. So more research with high-quality registries is needed. Again, this is what I'm going to focus on: Stratus, Trevo, and possibly the Dawn trial. This is something that we should do, and if we don't have that available, because these are relatively selected, then we at least need to have a robust county, community-wide data collection process. So what is needed in the system of care to get to these outcomes? I'm going to summarize again. We now have level 1A evidence that mechanical embolectomy is superior to best medical therapy in patients with large vessel occlusion. Number needed to treat anywhere between 2.5 to 4. We know that we can achieve these results if a stent retriever is used by an experienced operator with good reperfusion outcome. If we can achieve rapid process, meaning CT to groin under 16 minutes. If the patient's in a system of care where there's no transfer delays or other delays that impact the reperfusion under 6 hours. We need to reperfuse 75% of patients under 6 hours to get similar results. And if obviously good technique is employed, etc. So again, we need to focus on our quality, we need to focus on our outcomes. The good news about this is that the resources that we're going to put behind it are actually well spent. If you compare what we've expended on cardiac intervention, STEMI, PCI, the number needed to treat is actually relatively modest. Here, even in the most severe and sickest quarter, the number needed to treat from the PCA-T-2 trial was 17, ranging as high as 516. Now, this is admittedly mortality, but if you take the poor score between permanent disability and death and modified ranking 0 to 4, the number needed to treat in Swift Prime is 7.4. So it's a very powerful tool that we now have available, and we deserve the same resource attention that they got for cardiac PCI. Similar to what they did with field triage and going directly to the lab, we need to develop a very similar process for stroke. The question is, what is the best option for them? And we have a number of options. We have the CT ambulance, which is expensive, not really proven to be superior in our geography, especially when compared to a good process. We have score-based field triage, which we're right now doing in the region of the Greater Broward Medical Director, Gebemda region, which is largely cost neutral other than the training costs, and tends to avoid overload of the comprehensive stroke centers, and also allows the primary stroke centers to have buy-in into the process. Or we could go in the way that others have proposed with 100% bypass to comprehensive stroke centers. Certainly we have 8 comprehensive stroke centers in Broward, 4 in Palm Beach, I think 5 or 6 in Miami-Dade, but it's still unclear whether these comprehensive stroke centers have a proven process quality, and it's unclear whether those patients may not, in the vast majority, be bypassed unnecessarily. So this is really what I would propose. I think this is a much more down-to-earth approach. We have milder strokes that are IV TPA eligible going to primary. We have severe strokes that are strokes that are IV TPA ineligible going to comprehensive, provided the transport times are under 15 minutes, and we track our outcomes. That's really the system of care that I'd like to see in place. And we have a couple of tools that work for such a system pretty well. We're right now using the LA Motor Score, the very simple score you can see here, up to a score of 5, and the paramedic with some training can easily do that. If you have an LA Motor Score of 4 or more, it has a high sensitivity for large vessel occlusion, and it's basically the equivalent of our EKG, and we've deployed that together with some other questions in the EMS algorithm that's currently used in Western Broward. So I think this is one approach, but possibly not the ultimate end of it. There's others that we can discuss. For instance, there's an intriguing score coming out of Spain, and they looked at a race score of 5 or more, and were able to identify a large number of these large vessel occlusions with that cutoff. This is the score. It's relatively straightforward. It basically is a riff on the NIH stroke scale, but is therefore a little bit more detailed and sensitive than what is captured in the LA Motor Score, and may allow us to fine-tune the triage better. As you can see, a race cutoff of 5 seems to be where the best cutoff is. So what do we know today? In summary, time is brain. For each 30-minute delay towards intraarterial therapy, you use 14% treatment effect. So delays are not acceptable. Same for IV TPA. Treatment effect of IV TPA decays rapidly. We need to really quickly get our patients to treatment in ideally the golden hour in the first 60 minutes, not after door, but after onset. But certainly 100% of patients should be treated within 60 minutes of hitting our door. Stent retrievers are now standard of care. One of the things we should make clear is that there's a lot of comprehensive stroke centers that don't offer this treatment 24/7, 365. That is very, very important. We should not accept patients to be taken to a comprehensive stroke center to then find out, oh, we're actually not offering this right now, and you have to be transferred on somewhere else with an additional time delay. So that's something that the EMS community needs to track and really get down on. 90% of our stroke patients do not have a large vessel occlusion. They really need just rapid intravenous treatment, and we need to figure out how to best get that administered. I'm not sure that an EMS CT-based system is the most cost-efficient way to do that. I think we should only transfer to a comprehensive stroke center that has documented process quality. It really is not justifiable to transfer 90% of the patients to a center that may have longer door-to-needle times away from a primary, that may have better door-to-needle times. So that's really something we should discuss in the community. Currently, 26 out of 42 hospitals cannot document that they give TPA under 60 minutes. That needs to change. That's very important. And there is no evidence right now to support routine secondary transfer to a comprehensive stroke center because that's really too late. Thank you.